Okay, we're going to talk today about the new mental health parity regulations that were issued in September of 2024. My name is Brandon Long. I'm an attorney with the law firm McAfee Taft. This is not legal advice to you. This is just kind of a nice update or overview of what these mental health parity rules require. Mental health and substance use disorder benefits are something that if you ever have a family member or somebody close to you that needs the coverage, some of the barriers that people often have in seeking access are the purpose of these rules is to try to make it easier for people to overcome those or to eliminate barriers. So just a little history. In 2008, the original statute was passed that requires mental health parity. The law says that your benefit plan is not required to offer mental health coverage, but if it does, there has to be parity between medical surgical benefits on one side and mental health and substance use disorder benefits on the other. So if you offer mental health benefits and substance use disorder benefits, there has to be parity, think equality between med-surg benefits. The rules that were issued in September of 2024 specifically deal with something called non-quantitative treatment limitations, and they impose new requirements that basically say there has to be meaningful access to benefits for people seeking mental health and substance use disorder benefits. There's a kind of a new two-part test that I'm going to describe that plans now have to comply with as to these non-quantitative treatment limitations. And I'm going to start here in just a minute by explaining what a non-quantitative treatment limit is, because there's a lot of different definitions and it's kind of hard to keep track of them all. So just at a kind of an overview, the rules collectively, both the 2008 statute and the rules issued before now, and then the rules issued in September of 24 that we're talking about today, require you to kind of break down your plan into different pieces of the puzzle. So you think about kind of piece number one would be the financial piece. Think about deductibles, your out-of-pocket maximum, co-insurance, that kind of thing. That's the financial piece. The second category would be any kind of a quantitative treatment limitation. So if you have a number of visit limits in your plan, I often see now still plans that will say we cover chiropractic care, for example, at 20 visits a year or something along those lines. So that would be a quantitative limit because it's a number of visit limit. And then this last one is a non-quantitative treatment limitation. And these are things that are a little more difficult to define, and I'll give you specific examples of what those are. But when you're thinking about mental health parity, you really need to be thinking about the financial piece, the quantitative treatment limitation piece, and then the non-quantitative treatment limitation piece, which is mostly what we're focused on today, because that's what the September 2024 rules dealt with. When you're looking at those three components, the rules require us to divide a benefit plan into kind of 6 different classifications. Those are on your screen here: inpatient, in-network, inpatient, out-of-network, so forth and so on. So basically within each of these 6 classifications, you have to look at the financial piece, the quantitative treatment piece, and the non-quantitative treatment piece to make sure there's parity between med-surg and mental health benefits. So in terms of what is a non-quantitative treatment limitation, I think of it as it's easy to think about prior authorization. If you require someone to get prior authorization before they have inpatient mental health treatment, but you don't require prior authorization for inpatient med-surg treatment of some kind. The rules are focused on network design. These new September 2024 rules, one of the non-quantitative treatment limitations that they've identified is network design. Do you have an adequate number of mental health providers in your network? Do people have access to care? How many of the mental health providers that are in your network are taking new patients? Those would be examples of non-quantitative treatment limitations. Another example of a non-quantitative treatment limitation might be something like step therapy. If you have to take one drug before you can get another drug or get access to another drug that you're needed, or maybe you take a small dose of a drug, 3 pills before they fill a full 30-day supply. Anything like that is applicable to mental health substance use disorder benefits, you're kind of looking at that to say, hey, do we have the same thing with med-surg benefits that we're having with mental health and substance use disorder. Those are examples of non-quantitative treatment limitations that we're talking about and that the rule is focused on. So effective in 2026, there is a new something called a meaningful benefit requirement that requires a plan that says if a plan covers or provides benefits for a mental health or substance use disorder condition in any of those 6 classifications that I mentioned and was on the screen before, then you have to provide meaningful benefits in every classification. And so an example of this would be if your plan provided a coverage for prescription drugs for some sort of a substance use disorder condition, but you didn't provide inpatient, in-network treatment for that. If you only provided coverage for one drug to treat a condition, a substance use disorder condition, then you need to provide coverage in all 6 of those categories, and you couldn't just provide just the drug and not anything else. And so the rule says if you're going to provide benefits, they've got to be meaningful and they've got to be in every classification. In terms of what these mean, this concept of having meaningful benefits, you have to provide benefits for a core treatment for that condition in every classification. And again, we're talking about those 6 classifications that I mentioned. So if you have coverage for mental health and substance use disorder benefits or for a condition in any one classification, you've got to provide meaningful benefits or core treatment in all of those classifications. I think it's easier to think about this in an example. So the rules say, hey, if we've got a plan that covers autism, or it provides screening for autism spectrum disorder, and it covers outpatient, out-of-network developmental screening for autism, but excludes treatment for autism, including applied behavior analysis therapy, or ABA therapy. So if a plan provided coverage for screening, but didn't actually provide treatment if you were determined to have autism, the example the reg provides, it says you would violate the mental health parity rules if you provided only screening and not treatment, assuming you provide treatment for medical surgical conditions on the other side. So again, if you have medical surgical benefits and you generally provide coverage not just for screening but also for treatment, and yet on the mental health side, in this example, you're providing coverage for screening to determine if someone has autism, but then you're not actually covering the treatment, the ABA therapy they need, then that would be a violation of the mental health parity rules. So that's this concept of providing meaningful benefits or core treatment, which is effective in 2026. This is all new, okay? As it relates to non-quantitative treatment limitations generally, the rules create this new 2-part test that you've got to look at to determine if your plan satisfies these rules. And by the way, in terms of, and again, this is something you should consult with your lawyer about, in terms of ensuring compliance with these rules, it is ultimately the plan fiduciary, the employer typically, or its committee internally that is overseeing the plan. It's probably your responsibility to ensure that these rules are met and the standards are satisfied. And so to the extent that you have that responsibility and you have non-quantitative treatment limitations in your plan, there's this new 2-part test. One, the first part of the test is the design and application requirement, and the second part of the test is the required use of outcomes data requirement. And I'll tell you what those mean here shortly. So as it relates to kind of part 1 or step 1 in determining if a plan satisfies mental health parity, as it relates to non-quantitative treatment limitations, the plan must satisfy the non-quantitative treatment limitation requirements related to the design and application of the limitation, and this is applicable in 2025. This is a very kind of condensed explanation, but think of it about, if you look at your plan document, the way the plan document is designed and the way that it's applied has to be in a way that is non-discriminatory, and this is effective in 2025. So the design and application of your plan has to satisfy the mental health parity standards, and that's applicable pretty quickly. And secondly, this is new. It says that any non-quantitative treatment limitation has to satisfy this new standard that says you must ensure that no factor or evidentiary standard discriminates against mental health or substance use disorder benefits compared to med-surg benefits. And this is effective in 2026. So any factors or evidentiary standards or anything behind the scenes that helps a plan and operation determine if something is covered or not, those have to be non-discriminatory and they have to satisfy the rules in 2026. I think there will be more guidance on this particular piece, but this is a new thing that is applicable again in 2026. The second part of the test to determine if your non-quantitative treatment limitations satisfy the rule requires the use of outcomes data. This is all a very new thing, but the way I would encourage you to think about this is you're supposed to be gathering data, not just on a one-time basis, but you're supposed to design your plan and try to, in the first part of the test, you want to design your plan and make sure your evidentiary standards are non-discriminatory. And then you want to look at what's actually happening. And that's what the second part of the test, this outcomes standard requires, is that we look at the data and kind of say, hey, what is actually happening here? When we look at our plan, do we show that we have a lot of claims coming in for mental health and substance use disorder treatment? Or do we have a very small percentage? When we look at our plan design, does it look like the providers that are in our network are not accepting new patients? Or does it look like the reimbursement rates that we're paying those providers for mental health and substance use disorder for providing that benefit or providing our employees that benefit, does it look like those rates are lower relative to what we're reimbursing people on the medical surgical side or providers on the med surg side? And so it's gathering data, looking at the data, saying, hey, are people actually able to take advantage of the benefits that they need when they need them? And if you determine that your plan, that the data shows that there is not good access to mental health and substance use disorder benefits, then they want you to take action to fix it. And so again, the second part is to kind of gather the data and look at what's actually happening. And then to the extent you see problems, you're supposed to be proactively taking steps to ensure that you fix those problems on a go-forward basis. Several years back in 2021, there was a law passed that requires plan fiduciaries to have a comparative analysis done that demonstrates that your benefit plan, your medical plan, satisfies these mental health and parity and substance use disorder standards. And the rules that were issued in September of 2024 added additional details regarding what's supposed to be in that requirement. Under the law that was passed in 2021, the Secretary of Labor is supposed to be pulling at least 20 comparative analysis reports from different employers all across the country each year. And so they pull these reports and they determine to look at them to see if employers sponsoring plans are complying with the rules. The regulations in September of 24 add additional detail. They're pretty extensive. And again, I would encourage you to consult with your lawyer to ensure that you're putting together the comparative analysis for your plan to demonstrate compliance and that you're satisfying these new standards. This comparative analysis is very difficult to put together. It is not something that you can do quickly. It's probably not something you can do on your own because you need pieces from different, you might need some information from your network, you might need some information from your third-party administrator, you might need some information from your pharmacy benefit manager, but you're supposed to collect all this data and put together this analysis. The new rules that were just issued say that if the Secretary of Labor requests your comparative analysis, you have 10 business days to give it and to turn it over. And then there's a whole process that they go through if they determine that your comparative analysis is deficient. But the main thing I want you to know for today is you need to have this done. It's actually it's required right now, even though they've added some additional details in these new requirements or new rules. But this is technically something you're supposed to have. And if the government says, hey, XYZ company, we want to see your comparative analysis, you have 10 business days to give it to them. And trust me, 10 business days is not sufficient amount of time to put one of these things together. Done. One thing, or maybe the final thing that is new And kind of the final thing I'm going to mention today is for those of you that are subject to ERISA, which is most of you that are kind of private sector employers. This would, any of you that are governmental, maybe are Indian tribes that for their governmental plan, this would not apply. But for those of you subject to ERISA, there's this new requirement that requires the fiduciary of a plan to certify that they have engaged in a prudent process to select a qualified service provider to perform and document the comparative analysis, and then that they've satisfied their duty to monitor the service provider. This is new, but it effectively requires you, if you're the sponsor of a plan, to find someone that's qualified to help you put that comparative analysis together. Remember, I mentioned just a second ago that this is not something you can likely do on your own, and the rules kind of reflect that. I think a qualified service provider that you're going to need to engage to help you put together the comparative analysis so that you can make this certification that's now required is likely going to be an actuary, somebody that kind of fits into that category that can kind of help you do the all of the analysis that's required to put the analysis together. So lots to it, lots to this new rule. There's about 500 pages in this new regulation, and I've covered as quickly as I can here for you just to give you a little overview. But be sure to consult with your lawyer, and I would get to work now on ensuring compliance and don't wait. Thank you very much.